Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Lessons from Lockdown, Hepatitis Delta Elimination Strategies in the COVID-19 Era. I'm delighted to introduce our expert faculty today. I'll start with Dr. Robert Gish. He's a professor of medicine at Loma University and medical director of the Hepatitis B Foundation, both here in the United States. We are also pleased to welcome Dr. Pietro Lampertico. He's professor of gastroenterology at the University of Milan and director of gastroenterology and hepatology at the Policlinico Hospital, also in Milan, Italy. To link to the full program online, please visit the show notes for this episode. So let's get started and hear what Drs. Gish and Lampertico have to say about lessons we learned in the management of viral hepatitis during the COVID-19 pandemic.
Greetings, this is Bob Gish. I am based in San Diego and practice throughout California and Nevada. And I'm here today with my close friend and colleague, Pietro from Milan. Or is it Milan or Milano, Pietro?
Technically speaking, it should be Milano in the Italian way or Milan in the US. So it's up to you.
Thanks for being here with us today for this great presentation on Delta hepatitis or HDV.
Thank you very much, Bob. It's really a pleasure to be here. My practice is based in Milan, Italy, and we are very much involved in the management and treatment of viral hepatitis in general, and more specifically in the Delta. Actually, is our priority to improve the management of Delta patients. We also are involved in the COVID-19 management.
I work with the Hepatitis B Foundation. And as you know, Pietro, Hepatitis B Foundation's been at the forefront of advocacy for testing, linkage to care, trying to destigmatize hepatitis B, promoting research, policy. I'm just super happy to be part of this incredible organization.
Yes, I have to say that the Hepatitis B Foundation has done a lot of work from this point of view. I really have to congratulate you and the foundation. Maybe we are not so active in Europe from this point of view, but I think we have to learn from you, from the Hepatitis Foundation, because this is really crucial.
Well, the US has a very interesting dilemma. Part of it's underreporting of Delta hepatitis, which we'll get to a little bit later. But this was a claims database that we analyzed recently and published at the FAASLD, showing the distribution of adults diagnosed with Delta hepatitis. And they had to have, at least one HPV or HDV diagnosis logged into the claim system over about a 6-year period. This number was a little bit higher, 11% prevalence of Delta infection. We typically quote between 4 and 6% in the US. But again, this is a claims database, insurance-based, and may have some bias towards over-reporting of disease. Gives a nice age distribution here. But what's really important on this is the concentration of Delta in the Chicago area and the Northeast corridor. And of course, as we roll out more testing and more education, we really need to go to these hotspots. Pietro, what do you think?
Well, I agree. I think it's, first of all, I'd like to congratulate with you and all the people who were able to collaborate, because this is a great database. It's a huge database. We don't have anything like this in Europe. I know you are very good in putting together this data, and this is very impressive. You see at the age, I'm very impressed because you have a very uniform distribution of the proportion of patients according to the age category, which is probably not the same situation we see in our country or more in general in Europe.
Great points. Well, this will help inform us as we get new therapies. I'm very excited about this information guiding us with education. The other message that we really want to deliver is, well, there's 2 parts to this in this data set. One is people with Delta have a lot of comorbidities. And I guess we know that we're having an obesity epidemic, MAFLD, which I prefer MAFLD to NASH now. I think the new name is great. But look at the hypertension. Half these patients probably have some level of metabolic syndrome. There's a significant amount of substance abuse, HIV infection, which means they have a tri-infection or maybe even a quad infection. We're going to test those people for hepatitis C, of course. And a fair number of smokers. I mean, in the US, smoking is now down to about 16% of adults, in some areas much lower than that. But then you move to liver disease severity, and we know that this is the worst form of chronic viral hepatitis. And there's a large number of patients with cirrhosis at the time of diagnosis, but a lot of those have decompensated disease. And many of my colleagues who weren't testing for Delta a few years ago are now testing, and they're very sad because the Delta patients they're finding already are cirrhotic with some changes in bilirubin or maybe ascites or varices. We'll talk more about liver cancer a little bit later. Pietro, what do you think?
Well, again, very nice, interesting data. I have one question for you and one comment. The question for you is, what about if you compare these comorbidities with a similar cohort of HPV mono-infected? Are you expecting to see similar trends of history of smoking, hypertension, and substance abuse, or are you expecting a different prevalence? And in terms of comment, only 14% of patients with cirrhosis. I think this is an important point, and this is probably related to the fact that you are really looking at a very large database, not specifically generated in liver transplant centers or in hepatological centers. Because in our center, which is an hepatological center, 75% of the Delta patients have cirrhosis. So, the point I want to make is the picture would be completely different according to this sort of study that you will do.
These are fantastic points, Pietro. But as you know, in the US, we have a problem, and that is underreporting of many different things. And cirrhosis is underdiagnosed because people don't make the diagnosis often until they're decompensated. And people don't know how to make the diagnosis of cirrhosis with non-invasive testing, especially in a primary care population. So I think this number is probably off by a factor of 3. And then back to the comorbidities comments, there's some great papers from Mindy Nguyen and other people about comorbidities in hepatitis B, B as in boy. And I think that's a very important issue that we'll need to look at and think about comparing. And the last point on this slide is about testing. And the message here about testing, of course, is using the right test and interpreting and linking those patients to care. So the Delta antibody, and hopefully we'll have reflex testing soon to Delta PCR, and that would be absolutely key. So suboptimal diagnosis, suboptimal screening, we're going to change that with educational programs like this, I believe.
Well, Bob, actually, I agree completely with you. Despite the fact that Delta virus has been discovered 45 years ago in Italy, even in Italy, we do have this problem of diagnosis. Unfortunately, despite all the guidelines, many HPSAG positive patients have not been tested by antibodies. And the Delta RNA is not available, unfortunately, in many centers. But maybe we will go back to this issue later on.
Those are great points. And we also want to highlight under surveillance, even though the risk for liver cancer is much higher in Delta hepatitis. And we think it's Delta and cirrhosis, of course, probably 2 factors involved. So we need to link these patients to surveillance early as well. A genotype does appear to influence the risk of cirrhosis and cancer, but genotyping is not commercially available in the US. I don't think it's available anywhere in the world, and I don't predict it will become available for quite some time like we do for hepatitis C and B. I'm not advising that labs develop that. I want them to get quantitative PCR everywhere first and maybe rapid tests. What do you think, Pietro?
Well, actually, we develop a program in our unit by which we provide for free both Delta RNA quantification and Delta genotypes, not only for our patients, but also for all the patients in our region, for all the other centers. But I agree with you, really. Today, the priority is test for antibodies and test for Delta RNA. I don't think today the Delta genotype is so relevant. By the way, we are following 200 patients, Delta patients in our unit, and 99.9% are genotype 1 in our unit. So,
in my practice in San Diego, I have a large number of patients from East and Southern Africa. And there's, as you know, a whole group of other genotypes in the 5, 6, 7, 8 range that are in that group of people. And I have a lot of antibody positive, PCR negative patients. Fortunately, most of them have normal or near normal enzymes. So I'm not convinced that they're going to be RNA positive, but I should be able to trust the test. That's what my point would be here. So I think if they're going to do PCR testing, they need to have it for all genotypes. And of course, genotype testing would be good for research to have that available. Pietro, what do you think about vaccination as the ultimate way to eliminate Delta hepatitis?
Well, I think this is really a crucial point. Vaccination against hepatitis B not only prevents hepatitis B, but also, of course, by definition, prevents co-infection with Delta. And we do not have to forget that by vaccinating our people, really we are preventing not only the infection, but also liver disease, even cancer. And actually in Italy, we're kind of fortunate country because we started universal vaccination many years ago. And actually everybody from the age of 0 to 42 now has been effectively vaccinated in Italy. That's the reason why, for example, Delta patients born in Italy tend to be older than the age of 42, for example. But it's absolutely crucial, it's the only way. But vaccination is crucial, but even if you start vaccinate everybody today, you will never get rid of those patients with a severe liver disease. So we definitely need vaccination, but also new antiviral therapies.
Extremely important. The other thing that's happening in the US is the move to test all adults for hepatitis B following the ACIP's recommendation to vaccinate all adults for hepatitis B. The ACIP had this arbitrary 59-year-old upper boundary, which I thought was very weird. But anyway, vaccinate all adults, number one. Now, to vaccinate, you have to test before you vaccinate. So we're expecting very shortly for a statement that we're going to test all adults for the triple panel. And if triple panel negative, then link to vaccination. So I think sometime very soon in the US, we're going to really harmonize the testing, vaccination, link to further testing, and then hopefully AASLD will be updating their guidelines to test all B positive patients for Delta, because if they want to be evidence-based, the evidence is risk-based testing fails.
Well, I agree, of course. In Europe, we are not really following the AASLD guidelines in terms of Delta screening and testing. We do test every single patient as antigen positive with the antibodies against Delta. Is a universal testing. And in our view, this is simple, easy, and in our view is more effective at the end.
You just emphasized something about simplicity, and we had a great debate at HepDart just a short time ago about treating all adults who are HBV positive with any level of DNA. So instead of a 36-page guideline, we're going to take the guideline down to a couple sentences, which is treat this like an infectious disease, treat it like a stigmatizing disease. And that may help the message around Delta as well. What about some comments on COVID-19? You're an expert in that area. You've done some great research, Pietro. Do you want to take this message forward?
Yes, I think this is a very important message. So this is a nice paper which has been presented by Maria Butti recently at the American meeting. And this is an ongoing survey on viral hepatitis-related care pre and post-COVID-19 in a large number of countries, 20 European countries and 17 countries from the rest of the world. They really try to look at the hepatitis B outpatient consultations in this large number of centers. They were able to show a 34% reduction of the overall number of consultations, and also of almost a 40% reduction on new referrals for hepatitis B. And I guess also maybe Delta was included in this study. And many centers had more than 50% reduction of the outpatient consultations and of new referrals. And the same study, they also look at another topic, which is the hepatitis B treatment uptake. They were able to show a 17% reduction if you compare pre-COVID-19 situation with the post or during COVID-19 situation, with more than 50% of the centers really reducing significantly the number of hepatitis B treatment. And if I can make a comment from my side, hepatitis B treatment is a problem But in our view, liver cancer during this COVID-19 pandemic has been a major problem. Many patients, unfortunately, were not able to undergo the usual US surveillance. And actually, unfortunately, we had several people developing cancer without appropriate surveillance. Any feedback from US on this topic? Any personal experience, Bob, from your side?
I think this is a global event that where we're seeing this data. And yes, there's been a big impact, and switching to telemedicine, telephonic care has been good for some people who are isolated at home, who have transportation problems. But on the other hand, other people are intimidated by the technology, maybe the perception of lack of privacy. So testing is down, referrals are down, clinics down, new starts are decreased. Hopefully going to change, and we'll get back online as this next wave decreases.
Well, then I have a question for you, Bob. In many countries, now there is the COVID-19 vaccination ongoing. Probably Europe is kind of more advanced compared to US. But the question for you is whether you think the COVID-19 vaccination could be an opportunity for testing these individuals that are normally healthy individuals for maybe hepatitis B, maybe hepatitis C, maybe hepatitis Delta, or maybe something else.
I think we need to really carry this, I would say, statement or message forward. We were developing at the Hepatitis B Foundation, know your A, B, C, Cs, and Ds. And one of the two C's, of course, is the coronavirus. And the D, of course, would be linked to hepatitis B testing. But you could start the education there and then link those people to testing and vaccination as part of that whole message. And of course, the other part of the coronavirus world is rapid testing, right? I mean, I've got a box sitting, 4 boxes sitting to my left at my desk right now, ready to use tomorrow before I get on a flight, one of them. And rapid testing, hopefully for Delta, will come forward. There is one that was developed in Germany and has been published, but it would take some company with some commercial prowess to take that rapid testing into the world. It would be very helpful, especially in low and middle income countries. I would say Pakistan and Mongolia would be 2 examples, or Central Asia, where rapid tests and inexpensive testing may really accelerate testing and care.
Yeah, and we had an experience in our country where we developed a project during vaccination for COVID. We went to we have a big hub for COVID-19 vaccination. And actually, we tested a large number of these individuals coming for COVID-19 vaccination with the very rapid test for hepatitis C. And actually, we were able to test more than 7,000 patients in a few days with a rate of 1,000 individuals every day, which is, a large number of individuals to be tested in one day. And we developed all the logistics. And possibly this project could be potentially useful for other countries to test for, as you suggested, hepatitis B or Delta, or potentially, other markers, cancer markers. Why not in the future?
Yes, and the public, even though it's getting some anti-vaccine messages or misinformation about coronavirus, the global message that's come out of this is vaccines work, vaccines are safe. Rapid tests work. Rapid tests are good, even though I'd say the US FDA got some heat for moving too slowly on getting rapid tests out of caution. Sometimes in bureaucracies, caution wins for some reason. I don't understand when there's an emergency going on, but it is part of the politics of large organizations. But in the US, we are lucky in that we have some systems. There's 2 large lab companies, LabCorp and Quest. And then some medium-sized companies, ARIP, I work with, Viracor, Mayo Clinic a little bit. And they do have tests available at almost all of these labs. The only place that doesn't is LabCorp, which has a big footprint. But I am in dialogue with the LabCorp team. And as I understand, they'll be moving forward with full testing. So basically in the US, unless you're living in a rural community without a network access, you're going to have access to quality antibody tests and quality PCR tests, which I'd like to highlight. There's no FDA cleared tests. We don't use the word approved. We use the word cleared tests for Delta in the US because the commercial threshold is low. And I'd say commercial threshold, these are class 3 tests, cost about $40 million to develop a test that's class 3. You move it to class 2, which is a lower threshold, it's about $4 million. Imagine that, a factor of 10 cheaper to develop a test. And at $4 million, I think the big labs, such as maybe Abbott and Roche, just as examples, may find it appropriate to commercialize their Delta testing. Abbott already has great Delta testing. It's just not FDA cleared. How's testing in Italy? I know you mentioned that a little bit before, Pietro. Can you expand just a tiny bit?
Yes, well, the situation in Europe or in Italy is quite different compared to US. We don't have these large private companies providing the same test across the whole country. Actually, most of the regions or actually cities or even single hospitals try to organize independently, trying to go and check and buy the best possible test. So this is a problem. Overall, antibodies are available in most of the centers, but not all. And the Delta RNA quantitative test is available in some large units like our unit, but not in all units. And actually, that's the reason why we develop a project by which we are providing for free this HDV RNA quantification for not only our patients, but also patients from other centers. But Bob, I think we have to make a comment on the Delta RNA quantification because, to my knowledge, there are many tests outside, but not so many tests are pan-genotypic. And the quality of the test is not always perfect. What do you think?
Yes, that's a major comment. Emmanuel Gordian, who I consider the global leader in Delta testing, fantastic person alongside many partners in Europe with Jean-Michel Pawlowski, of course, the network that Heine Wiedermeyer put together with this testing about 6 years ago, almost 7 years ago, did highlight the irregularities or the inconsistencies between labs, and a lot of it was genotype dependent. They wanted a standard test, but they said, okay, we're going to move forward with a standard test for genotype 1. It's the most common at least in Europe and the US. And that's the standard that they have. The primers are for genotype 1, not through the other genotypes. And of course, we're using numbers, even though they changed the names of the genotypes to written names based on geography. So that is a challenge. And I think they do need to have genotype consistent quantitative PCR testing. The message I want to have here is there are qualitative RNA tests available, but they're not standardized. Data is not published. And I caution people not to use qual PCR and not to use the Delta antigen test, where also we have very little information, very little standardization. Would you agree with those two qualifiers, Pietro?
Yeah, I agree. Absolutely. We're not using the Delta antigen. We are using only the antibodies and the HDV RNA quantitative test. But there is another issue, Bob, I'd like to mention. Is not only the kit, but also the kit you are using to quantify Delta RNA, which of course must be the best possible available, but also the way, the methodology of RNA extraction makes a lot of difference. There's been already a couple of studies being published. Also, our experience goes on the same line. If you use a manual extraction, this is much more efficient than automated extraction. And the difference is approximately 1 log. So whenever you go to these large companies, doing a lot of tests, you want to be sure that they will not use the automated RNA extraction, but they will use the manual extraction. This is very important.
Well, the total anti-Delta, fortunately, is the IgG test. There's very little IgM detected in that total antibody at the different laboratories. So this is a super simple test to do. IgM, unfortunately, stays elevated and measurable, positive, even in patients with chronic disease, even though it's a lower titer. When we order these tests, we usually don't get a titer back. You just get a positive, negative result. So we bypass IgM unless you are absolutely convinced it's an acute case. You'll probably figure that out without the IgM anyway. And we mentioned delta antigen really does not have a role in patient care. And of course, you're not going to do delta RNA without a delta antibody being positive. But because I think in general, the delta antibody tests have a very low false positive rate. And the sensitivity ranges from 95 to 99% in my interpretation. Would you agree with that? Those high numbers for sensitivity, Pietro?
Yeah, I agree. I think it's a very robust test. And actually, we did not have any major problem in the past. The only point I like to make is that in the past, delta RNA was not really available in many countries or in many centers. So it was very difficult to understand whether total anti-delta was positive because of an active delta disease or was positive because of an inactive delta, only a previous delta infection. So now that the delta RNA is available, a good tests are available, I think will be easier to confirm your data.
Great. That's very, very useful as well. So just to simplify this just a little bit, you've got a surface antigen positive patients. Hepatitis B Foundation, like EASL, recommends checking all patients for delta antibody positive, link those to quantitative PCR, and then link those patients to care. And even though in some parts of the world, there's no approved therapies for delta infection, interferon is still an option, even though not approved. And there are new therapies that are approved in at least 3 countries in Europe and available in many other countries. What I understand, the patients getting access to this new treatment. So there's a reason to test for delta. Some of it has to do with just watching patients more closely, with surveillance, with lab testing, with education, testing contacts for delta as well. So I think those are really important take-home messages. Do you have any other comments on that, Pietro?
Well, my comment is really a general comment. My message is very simple. Physicians must always think about delta, always test for delta, and always, with interferon, if it's the only drug available, or with the new drugs, if they're available, treat delta patients because they have a very progressive liver disease. The earlier you treat, probably the better. And these patients, at least in our experience, these are young patients. The age is 45, 50 years old ladies dying of decompensated liver disease or being transplanted because of ACC. So these are the patients that we see, and we really have to manage and treat these patients as soon as possible.
Okay, so looks like we are heading to a wrap up on this. My important concluding remarks are, let's educate, let's link to testing, let's link to care. Care includes looking for more serious liver disease if delta patients are positive, monitoring patients more closely, managing MAFLD in those patients more aggressively, because that would be another amplifier for risk of progressive disease. Care doesn't just mean we have a pill or an injection, even though that is part of our care. We really need to get the message out. It's time to test everybody for delta because there's a lot of things that we can do. And we have a simple path forward, I believe. Pietro, what are your concluding remarks?
Well, I think educational activities are really crucial for delta. I think many physicians really forgot about delta for many years. Actually, the diagnosis of delta is so easy compared to hepatitis B. Just have a couple of markers. It's simple. If you have one positive marker, you go for the second one and it's finished. So we really have to stimulate everybody to think about delta, to test for delta in everyone, as every S antigen positive patient or individual, and monitor closely because these patients tend to have a progressive liver disease. And of course, treat these patients as soon as possible.
Fantastic.
Thank you so very much to Drs. Lampertico and Gish for sharing that engaging discussion, and thanks to our listeners for joining in. As a reminder, to view the full educational program online, Lessons from Lockdown, click on the link in the show notes.